Hello, everyone. Welcome back. Awesome Team 1. Thank you for joining me. Today, I would like to discuss the medical billing and coding with the electronic health record. That was definitely one of our hottest topics previously in ways to avoid fraud and abuse and how the EHR helps us do that. So I hope you enjoy it. Thank you. And here are a list of those unfamiliar terms you'll hear me mention quite often throughout the presentation. CPT codes, which are procedure codes, ICD-10 codes, which is our diagnosis codes, our E&M codes are our evaluation and management codes mandated by CMS. And of course, CMS is the Center for Medicare and Medicaid Services. So here we go. This is where it all begins. It starts with that level of service, that CPT code that establishes the office visit that took place that day. The higher the level, the higher the reimbursement, but the more documentation is required. So these are codes that would be associated with the new patient. These are codes that would be associated with an established patient, and these are the ones that we'll focus on for this presentation as we go through and discuss the documentation requirements in order to bill and be reimbursed for services for that particular code. And just to prove my theory about physicians and coding, I wanted to show you these little cheat sheet cards that I make my physicians carry around in their pocket in order to accurately document office visits depending on the level of service. So for instance, this is your new patient encounters that I just showed you, and these are the established patient encounters that I just showed you. So if my physician wants to bill for a 99203 visit, the history must include all of these things, which I'm going to break that down for you in just a moment. The exam must include 5 to 7 bullets from the exam portion guidelines from CMS, and the MDM must be a minimum of low complexity, and the time that he must spend with the patient is 30 minutes. Okay, so as we discussed previously, here are those 3 categories: history, examination, and the medical decision-making piece. Those are the 3 elements that are required to bill a higher level of service. Down here, these are your service levels. This is hospital on the bottom. Here on top is the outpatient visits that we were talking about. This is new. This is established. So if I want to bill a 99204, for instance, for the history portion, I have to be at a comprehensive status. Comprehensive status in the history portion right here says I have to have 4 elements from the HPI. Here's your HPI right here at the top. I have to have 2 elements or 3 elements on a new patient of the PFSH, which is here. These 2 are usually met very easily because it's definitely questions that we ask at every visit, including the chief complaint. The biggest issue is going to be here with the review of systems, and for a comprehensive visit, it says 10 to 14 systems need to be reviewed. Here are your systems here. So physicians would be required to review 10 to 14 systems. Then if we come back down here to our CPT code, we also have to be comprehensive in the exam category. And here we are. If we want to be comprehensive, all bullets in constitutional and psychiatric boxes, which is here and here, have to be completed, and 1 bullet in the musculoskeletal has to be completed here. If we are going to be moderate MDM, then our points have to be 3 data points, 3 problem points. Here are your problem points. Here are your data points. So it is very easy to see that when we are trying to get physicians to be compliant, concise, and complete as far as documentation is concerned, it's very difficult. And as if the 3 levels that we just reviewed previously were not enough for physicians to remember, we also have to make sure that the time that we spend with the patient is within the appropriate range in order to bill for whatever level of service is that you're billing for. So for instance, if I were billing, now this is established patients, so instead of the 0, we have the 1. But if I were going to bill a 99214, I would have to spend 25 minutes on complete care. 13 minutes would be face-to-face with the patient. So how do we track that? Our nice EHR system is going to assist us tremendously with the previous slide that we just discussed, as well as this one. So here's my patient, my test patient right here. I'm going to check them in. That's going to be our start time as far as determining a window for when their check-in was complete and when they left. We would check them out here. This is the template associated with the EHR where we have set up all of the components required for specific service levels. So that history that we talked about, the vitals that we talked about that had to be associated with the chief complaint, and the things that needed to be included in the history, we've added all of those to the template. This is a new patient exam, so all 3 of those components completely done were required, so we incorporated that into the exam. The studies, if any were done, they would list there, and then of course the anatomy and physiology would be listed here. And then of course there's subnotes if they wanted to make comments. But everything that you see here is what is required in a complex visit, the higher level visit, in order to get reimbursement from the government. Okay, so our next step is determining the ICD-10. Here's the thing with ICD-10 coding. This is what supports medical necessity. We are saying this. For this diagnosis, it was necessary to take this long to see this patient. It was necessary to order all of these tests for this patient. So basically, you are trying to prove that the CPT code or the level of service that you provided is supported by your diagnosis code. So this is the part of the template where we can put in the ICD-10 code. So I can select aneurysm. I'll search that here in my search bar. And if I were to choose unspecified site, which is not enough information, my EHR is going to prompt me to give more specific information. So I have to click on a more specific diagnosis, which is required by the CPT code, the level of service that I chose when I scheduled the patient. So you can see here, it's prompting me to click it. That's okay, because I have met all of the requirements on the previous tabs, the vitals, the histories, review of systems. So if any of those were left blank, it would ask for more documentation. Again, this is how we've set our EHR up, and these are things that providers can do to ensure that documentation is complete. The issue is tying the level of service, that CPT code, to the ICD-10. So unfortunately, not all EHR systems are set up to assist with the ICD-10 coding. So for instance, if a physician were actually coding a ticket for a particular level of service for this diagnosis that we see here, all of these codes would be required to meet that higher level of service, that CPT code. Therefore, it is much easier to be able to utilize an EHR to obtain this information. Personally, I feel that this would be the end result. Ha ha ha. The practice of medicine has undergone a significant transformation because of federal regulations, coding and reimbursement. It's medical coding is a language all of its own. So it's not an exact science. Documentation of medical necessity must be supported in the medical record. It is subject to intense review, folks, by the insurance industry. These fines and criminal liability are no joke. They are auditing more than they have ever have, and actually have teams in place that are given a region. Every state is in a different region, or a number of states in a particular region, and they are going and they're auditing, and they're going to hit every facility, checking to make sure that we are doing what we're supposed to do. So again, qualified medical coders is the only prevention of violation of CMS rules and regulations associated with billing. And so, in summary, what you can definitely take from this is that the electronic medical record or health record, while not perfect yet, it definitely assists in reducing the risk associated with fraud and improper billing. Level of service and documentation, it helps us tremendously in ensuring that the documentation is complete for the level of service that was provided. It assists quite a bit with the accuracy of ICD-10. While not foolproof, it does assist in getting those codes right to show that the medical necessity behind the office visit level, and again, decreases the risk of liability. So I hope you enjoyed my presentation. Please let me know if you have any additional questions. Thank you so much for tuning in.